Okay, good morning, everyone, and welcome to this Friday's Grand Rounds. It is always nice, even an honor, to get asked to present a speaker at Grand Rounds. But for me, it is a different level of honor to be asked to present a graduating fellow, and especially when they're as spectacular as this Friday's Grand Round presenter, Dr. Lee Eschenroeder. And so Lee completed both his BA in bioethics and MD degrees at the University of Virginia, after which he matched for residency here at the University of Washington. And this was also when I first met Lee. After a couple of hours at the cardiology A service, I immediately knew that he needs to be our cardiology fellow here. And so our little evil plan worked out, and he was here with us for the past 3 years. I will allow myself to speak on behalf of many other attendings, I'm sure, and say that it made all of us very, very happy to come into clinic or walk into a service for the first day and to find out that Lee is our fellow. Lee is an extremely thoughtful, thorough, smart, and hardworking clinician. And after working with him on numerous occasions, I learned the unfortunate truth, at least for myself, that no matter how well I prepare for clinic, Lee will always know the patient better than I will. And if there's anything in my plan that doesn't make sense or frankly wrong, Lee will pick up on it. And so he's truly a fellow that any fellowship program should be very proud to have as a graduate. Lee's also a wonderful conversation partner on non-medical related topics, which I personally love. And I want to say that perhaps the only thing that comes close to matching his wisdom is his physical shape. So I don't know how many of you know this, but last year we conducted a prospective study in our CPET lab for congenital heart disease patients and needed some healthy volunteers. And among all the spectacular fellows who demonstrated some impressive exercise skills, Lee's peak VO2 was by far the highest, the kind of numbers that you could typically see in the Olympic tryouts. He was all over 60. It was over 60. It was, yeah. And so Lee will be graduating from his cardiology training here at the University of Washington in this coming July, and he'll be moving to Brown, where he'll be an attending cardiologist. I personally, and I'm sure that others as well, will be very sad to see you leave, Lee, and I'm sure that we will all hear much more about him in the future. Today, Lee will be speaking to us about a great topic, which is rapidly developing around the nation and very much so here at the University of Washington, which is individualized approach to thoracic aortic disease. Lee, thank you for everything that you've done with us for the past 3 years. You've been amazing. Take it away.
So outside today's scope, this is a large topic, and things we won't have time enough to cover will be emerging techniques in aortic and aortic valve surgery. For those interested in that, I encourage you to review Dr. Chris Burke's Grand Rounds from 2021, The Living Aortic Complex, and Techniques and Innovations in Vascular Surgery. I would encourage you to review Dr. Sarah Zettervall's Grand Rounds from just late last year about some of the exciting things happening there. Just to start with some of the patients we typically encounter in the aortopathy clinic, where I've been privileged to work with Dr. Otto, but also in a typical general cardiology clinic. On any given day, we might have a 74-year-old male referred for incidentally diagnosed dilated aorta, a patient with bicuspid aortic valve disease and ascending aortic dilation, or a patient, a younger patient with a family history of aortic dissection referred for evaluation. And so each of these patients, represents different clinical questions and different demographics and risk factors. But the common question for all of them is what is my patient's risk of aortic dissection? This is the complication that we are concerned about with thoracic aortic disease primarily, and what we are trying to better understand to be able to predict and prevent for these patients. Just by way of a basic review, when we consider the anatomy of the aorta, that includes 4 primary components: the aortic root, which is from the aortic valve annulus to the sinotubular junction, and includes the coronary sinuses; the ascending aorta from the sinotubular junction to the takeoff of the innominate artery; the aortic arch with the branching cerebral vessels; and the descending thoracic aorta. The aortic wall, which we'll touch on in some more detail here today, includes the intima, composed of endothelial cells, which can sense the luminal environment; the media, composed of elastic fibers and vascular smooth muscle cells; and then the adventitia, which is sort of the structural support for the aorta, including fibroblasts and collagen. As many in all in this audience are familiar with aortic dissection, the disease process is been theorized to occur via an out to in process through an intimal tear from the true lumen, and then propagation into the aortic media and dissection through the creation of a false lumen through dissection of the medial space. There's also theorized sort of the in to out hypothesis, where development of an intramural hematoma within the medial space can then subsequently cause that break in the intima. But the favored sort of mechanism is that intimal tear leads to hemorrhage within hematoma formation within the media through a diseased medial space. Classification, as we're also all familiar, I'm sure, is typically through the Stanford type A and type B. Those dissections of type A involving the proximal ascending aorta, and type B dissections involving the descending thoracic and thoracoabdominal aorta. We'll be focusing primarily on the data around type A dissection today. The epidemiology and mortality of thoracic aortic disease. Fortunately, this is overall a rare condition, but one that's highly morbid. So 15 cases per 100,000 patient years in the middle-aged population with a male preponderance. And that incidence can increase as high as 35 per 100,000 patient years in those of a slightly older demographic, age 65 to 75. Importantly, this is a highly morbid condition. Mortality is 1% to 2% per hour, and sudden death can occur in up to 50% of patients, again, providing a strong motivation to be vigilant in the detection and prevention of this condition. So how do we assess risk? The assessment of aortic diameter that is common in our clinical practice primarily traces back to studies in the early 2000s that looked at the risk of aneurysm and dissection in patients. One of the initial studies that informed this was by Borger and others in 2004. They looked at 201 bicuspid aortic valve patients undergoing aortic valve replacement, followed them for a period of 15 years for aneurysm, dissection, or sudden death, and noticed discrete cut points between aortic diameters under 4 centimeters compared to those in the 4 to 4.5 range and greater than 4.5 centimeters. Subsequent analysis of a larger population done by Parturi and others of the MESA database and registry similarly showed a dramatic increase in the relative risk of aortic dissection once an aortic diameter reached over 4, but really over 4.5. And that sort of informs our current nomenclature, which is that, above a diameter of 4 centimeters, we refer to the aorta as dilated, and above 4.5 is frankly aneurysmal. And we'll see other terminology used, such as ectatic aorta or enlarged aorta, but these are in the 2022 guidelines, the preferred terminology based on some of this data. So how well does this data work in predicting these patients and preventing events? Well, not long after the publication of these, we saw that the diameter of 5.5 centimeters, which was the diameter indicated for replacement of the aorta, may not have functioned well as a predictor. This was from the IRAD registration published in 2007. And they looked at 591 patients who had presented with type A aortic dissection from 1996 to 2005, and saw that a full 60% of them presented with an aortic diameter under 5.5 centimeters. And even if we had taken a more conservative threshold of 5 centimeters, 40% of patients would present with an aortic diameter less than that. And whether a patient dissected with an aortic diameter under or over these thresholds, there was no significant difference in clinical outcome and mortality. The authors of this article, I think, prudently concluded, we do not recommend that the guideline be changed, but rather that the premise for the guideline continue to be examined. To prevent aortic dissection and its often catastrophic outcome, we need better risk predictors to identify those patients at risk. And that mission has been a lot of the work of the work of the last 20 years or so, trying to work towards a better understanding of that, and what we'll talk about today. Some of the first attempts to better risk stratify these patients came through identification of other methods of anatomical measurement. So, for example, ascending aortic length, this publication from the Eleftheriades group at Yale in 2019, was looked at as an alternative mode of prediction of aortic events. This measurement from the aortic valve annulus to the branch point of the innominate artery adds some stratification among patients. So in the top figure, we see that the sort of distribution of AAEs, acute aortic events, or aortic adverse events, excuse me, based on aortic diameter. And then we see the distribution of the curves, and we separate that out into aortic length. The combination of different parameters, in addition to indexing against something like patient height, for example, can lead to a more granular interpretation of a patient's risk. So this is a nomogram created by the investigators in this study, which essentially taking the summation on the x-axis of aortic diameter and aortic length plotted against the patient height can stratify out between between low, moderate, high, and severe risk groups. How is this represented in the 2022 guidelines? We see a number of alternative options for normalizing aortic dimensions for body size. Aortic size index, which is diameter over the BSA, notably is weight dependent and may be a limitation where we may not expect a patient's aortic size to fluctuate dramatically with changes in weight. Other indexed values are such as aortic height index and the cross-sectional area to height ratio are indexed against the patient height. And then, as I mentioned, the ascending aortic length can be considered. Just a note, Z-score will sometimes come up in conversation or consideration, but this is really a pediatric tool and not for use in adults. And again, just showing how this is represented in our most recent guidelines, we do see that in the case of sporadic aortic aneurysm, surgical indications for the aorta can include under 2A and 2B recommendations these indexed values to help individualize that approach for patients, particularly those patients who represent either end of the spectrum of physical size, either much larger patients or much shorter patients. So, this was sort of represented one effort to have a more individualized and granular understanding of how just the aortic anatomy could predict risk. But I want to move next to talk about the heritable aortopathies, which have really represented a challenging area because these patients, have demonstrated a different clinical course from others who might present with thoracic aortic disease. And just to start with a representation of this with a case, this is a patient who, fortunately, we continue to follow in clinic, but had a presenting story, 33 years old at the time of their event, had sudden onset of chest pain while eating dinner with their partner. This was accompanied by altered mental status and hypotension. They presented emergently to the ER where they were noted to be bradycardic, hypotensive, and a prior history of mitral valve prolapse, although no prior imaging was available. The patient was appropriately taken for a CTA, which revealed an acute aortic dissection extending from the aortic root to the infrarenal abdominal aorta, and was appropriately emergently taken to the OR for surgery. Transesophageal echo from the operating room revealed a significantly dilated aorta, measuring up to 6.5 centimeters, with consequent significant aortic regurgitation. The patient was taken care of by Dr. Deroux and fortunately was able to undergo a successful valve-sparing root replacement. In the OR, it was actually noted that the tissue quality was extremely delicate, almost translucent tissues, and the patient's partner called during the case to inform them that they had previously been diagnosed with Ehlers-Danlos syndrome. And so, of course, given the presentation and this concern, genetic testing was sent, which subsequently revealed a pathogenic variant in the fibrillin-1 gene diagnostic of Marfan syndrome. So beyond considering just the basic anatomy of the aorta predict risk, we want to really think carefully about the etiologies of thoracic aortic disease, which primarily break down into three large groups of inherited aortopathies, the syndromic and non-syndromic distinction being one of decreasing importance as time has gone on and genetic testing becomes more prevalent, but is more reflective of the ability to diagnose these patients based off of extracardiac syndromic features in the past. Congenital conditions associated with thoracic aortic disease, and then the sporadic or acquired groups, including what would be termed degenerative disease associated with hypertension and atherosclerosis, as well as aortitis in the setting of things like inflammation and infection, which comprise a much smaller portion of overall prevalence of overall incidence of thoracic aortic disease. Among these, I will just mention that the data is not can be hard to obtain, but essentially the majority of the overall incidence of thoracic aortic disease does come from this sporadic and degenerative aortopathy related to hypertension and atherosclerosis as common cardiovascular conditions. But increasingly, the inherited aortopathies represent a larger share of the thoracic aortic disease that is seen and have been estimated as high as 20%. So we move from considering these as the diagnosis of a anatomical issue, an aneurysm, to an actual underlying disease state of the aorta, an aortopathy. And we can essentially see that these patients behave very differently despite presenting with some form of thoracic aortic disease. The dissection prevalence in degenerative or sporadic aortopathies is much lower. The age of dissection is around 65. And in the congenital conditions, and particularly in the connective tissue disorders, we see a much higher prevalence of type A aortic dissection occurring at a much younger age, often in the third or fourth decade of life. This represented in another figure essentially demonstrates the same point a bit more visually. We can see in blue is represented the elective aortic aneurysmal surgery for prevention of dissection, highest in the bicuspid aortic valve group in the top right. But the presentation with type A dissection represented by the orange bars, or even cardiovascular mortality, is much higher, particularly in these inherited aortopathies, Marfan syndrome in the top left, Loeys-Dietz and non-syndromic heritable thoracic aortic disease in the middle row, and then particularly vascular Ehlers-Danlos on the bottom right, which we'll talk about. Patients so often dissect at a normal aortic diameter that it's difficult to ever catch them before an acute presentation. So we know these diseases are different, and then the challenge has been to discover what exactly is happening and how we can better assess these patients and care for them. And so if we go back and sort of think about how we approach disease processes, we can remember Rudolf Virchow in the 19th century, who encouraged the students to think microscopically. And so studies that have looked at the aortic wall tissue to actually see what pathological differences may exist have seen, for example, in this slide of a patient with a normal thoracic aorta and trileaflet aortic valve, the standard intimal thickness is quite different compared to those patients with bicuspid aortic valve disease or Marfan syndrome, where the intimal layer is much reduced. And remember, this is sort of the first step of our pathway of dissection, is that initial breach of the intimal layer. Other features of vascular aging or risk of a dissection maybe don't follow the same pattern we would expect. So looking at overall medial degeneration among these patients, it was found to be greatest in those with a trileaflet aortic valve and dilated aorta, the TAD group, and those with Marfan syndrome. But despite what we might expect, actually not that prominent in patients with bicuspid aortic valve disease, whether they had dilation or not. And when we look at smooth muscle cell nuclear loss, Again, we see the same pattern here, the blue circles denoting smooth muscle nuclei and the red arrows showing areas of nuclear loss, greatest in the thoracic aortic disease and, the trileaflet aortic valve and Marfan group patients. And so kind of taking studies like this in their totality and looking for patterns here, we generally see that among patients with trileaflet aortic valves and aortic disease, who are often admittedly also older, we see increased markers of vascular aging and the presence of inflammation and atherosclerosis. However, there's overlap with these patients and those with Marfan syndrome in the degree of medial degeneration, elastic fiber fragmentation and disorientation, and vascular smooth muscle cell loss. And then those patients with congenital or inherited aortopathies notably demonstrate less inflammation, less atherosclerosis, and in some cases, in the case of bicuspid aortic valve disease, may have less medial degeneration. So this study doesn't necessarily provide answers, but it may certainly be hypothesis generating. And I think to kind of walk through what is sort of the prevailing hypothesis for how this occurs at the cellular level, I want to talk with you about the mechanosensory vascular smooth muscle cell complex. This is sort of the basic unit of disease that guides a lot of the current research in inherited aortopathies. And so the basic premise that I want to start with is that in the aortic environment, we take an environment that typically sees pressures of 100 to 200 kilopascals generated throughout the cardiac cycle, and then is able to mitigate these and transmit these reduced to the level of 3 to 5 kilopascals at the level of the vascular smooth muscle cell. And so how is that force taken and mitigated across that environment? It essentially comes through this complex, which includes the vascular smooth muscle cell, includes cytoskeletal elements, actin and myosin, that are able to involve with cell function. The extracellular matrix composed of elastin and collagen, and then modulation pathways in that between the two, including the TGF-beta pathway, which is essentially a repair pathway within the extracellular matrix and interacting with the vascular smooth muscle cell. And then these are combined through cell adhesion proteins, integrins, that actually incorporate signals of mechanical stretch and activity, and these are translated into cell regulation and programming. And so I'll come back to this figure a couple times just to try to give us sort of a firm foundation to kind of anchor this in, because the figures are going to get more complex. Considered another way, the aorta routinely sees circumferential and axial stress during the cardiac cycle. We've mentioned the layers of the aorta here. In instances of increased intra-aortic pressure, there is sensed force within the complex I described. And that sense force leads to adaptive remodeling through thickening of the aortic wall, proliferation of vascular smooth muscle cells. When aortic pressure is reduced, there is similarly a remodeling process that occurs. There's vascular smooth muscle cell apoptosis, there's proteolysis, and the wall thins. But what happens if this is occurring not because the pressure is lower, but because the pressure is simply missensed? So if there are defects in the extracellular matrix or defects in actin and myosin filaments, how might that lead to a maladaptive response in which the aortic wall thins over time, becomes more risk of dissection, loses its vascular smooth muscle cell population, but it's instead due to defective elements of this complex that I described. So we can go from Rudolf Virchow in the 19th century to our very own Arno Motulsky, who founded our Department of Medical Genetics, who said, think genetically. And so if we take this mechanosensory complex and think about its components, there are modulation pathways. There's the extracellular matrix. And there are cytoskeletal elements. How might these be affected by genetic changes? And it's these main buckets that form our primary groups of identified genetic abnormalities in thoracic aortic disease. So keep this image in your mind, except turn it on its head. And Within the extracellular matrix, we find the fibrillin and elastic fiber mutations associated with Marfan syndrome. The COL3A1 mutations involved with the collagen organization in that space associated with vascular Ehlers-Danlos. We see the elements of the TGF-beta pathway starting in the extracellular matrix and then continuing into the vascular smooth muscle cell, where the genes that you may recognize from Loeys-Dietz syndrome are involved, the TGFB and TGFBR mutations, as well as the SMAD mutations. And then those elements of the cytoskeleton, the MYHA11, ACTA2, and PRKG1 mutations. So I just want to sort of keep framing it as these three big buckets so it doesn't become an alphabet soup of letters here that all sort of relate to how that complex functions. And it would be a talk in and of itself to go into the story of any one of these genes, its discovery, its characterization, what we know about it today. But just to give sort of a representative example of that, I'll talk a little bit about fibrillin-1, which is the gene we've learned the most about. So fibrillin was discovered in the 1980s, first as a protein. It was associated with histologic changes in Marfan syndrome in 1990 and was first successfully mapped to a patient with Marfan syndrome in 1991. Since then, more than 30 years have gone by. We have assembled a huge amount of knowledge about the gene itself, including over 2,900 reported variants. And so I think oftentimes when we're considering these patients in clinic, we're thinking kind of fibrillin mutation, yes, no. And in fact, there's a great deal of granularity that's come over a long period of study for this gene. The typical interaction of fibrillin-1 is predominantly involved with the TGF-beta complex. Fibrillin binds in the extracellular matrix and essentially holds TGF-beta in a latent complex in that space. The presence of mutated forms of fibrillin can lead to loss of the inactive complex and chronic TGF-beta activation. That is thought to propagate into changes that lead to arterial disease and risk of dissection, although the exact mechanisms are not precisely described. And even our own Dr. Dicek, before he passed, was involved in some of this research trying to elucidate this pathway more, and it's continued by his colleagues. Why is it important to kind of understand this granularity? Well, it actually does make clinical differences. The specific genotype has been shown to impact survival in Marfan syndrome. So this study in 2016 looked at patients with either a haploinsufficient mutation, that is one non-functional allele, and then their fibrillin being produced only by the remaining functional allele, versus those with a dominant negative mutation, one mutated allele producing a mutated or partly functional form of fibrillin, as well as the remaining normal allele. And what they saw, particularly in the figure on the right, which is the cumulative incidence of mortality and dissection, on the left is just a mortality shown, they saw a significant difference between these groups, that those patients with a completely non-functional allele, the haploinsufficient patients, had higher rates of dissection than the other Marfan syndrome patients who had the dominant negative mutation. And just shown here in another table, we see that those primarily driven by the incidence of dissection, the hazard ratio, unadjusted and adjusted between these groups, was greater than 2 for elevated risk in the haploinsufficient population. So appreciating that this complexity exists and that this range of variants must be considered, we come back to our patients. Which patients do we test? Remember, not all thoracic aortic aneurysms are inherited aortopathies, and which genes do we test them for? Well, you've seen this slide before. The cost of genetic testing has fallen dramatically over the last 20 years. And so access to genetic testing has become, fortunately, much more prevalent. But with being able to test that many more patients, we have a flood of data that then requires interpretation. It's important to remember that most genetic tests will return with variants of uncertain significance. So just showing how the rise of detection of variants of uncertain significance has increased exponentially over the past several years and may represent up to 75% of genetic test results. and that genetic tests are not positive or negative, right? We don't get the yes/no interpretation. We get a result that may look like this and may read like this. The single base pair alteration affects the first position of coding exon 47. It results in substitution of a completely conserved aspartic acid by glycine at position 1930 in fibrillin 1 encoded by this allele, which is the first residue of the 29th calcium-binding EGF-like domain. I usually don't make it very far into this interpretation, or at least did not before giving this talk. But the reason for this level of detail is not simply academic or to preserve a specialty practice, but it's because there is tremendous intragene variation within even a single gene such as fibrillin 1. So fibrillin 1 is a large gene greater than 350 kilodaltons. It has 65 exons and coding regions. And the distribution that we see within the variants of the gene is considerable. Note that on the bottom of the figure here, the absolute count of each range is often in the hundreds. So we're considering a considerable number of variants. About a quarter are known to be pathogenic, half are likely pathogenic, another quarter are uncertain significance, and then just 2% likely benign. And the exact type of mutation matters as well. So the nonsense and frame shift mutations have a much, as well as involvement of cysteine in the calcium binding EGF domain, have a much higher likelihood of pathogenicity among others. And a similar figure could be developed for virtually every gene we test for with varying distributions among them. And so just being aware of the array of results that one might get is essential when considering genetic testing for our patients. It's also important to note that genetic tests are not static. So this was kindly provided me by Dr. Hisama, who got an update 23 months later after sending genetic testing for a patient that, fortunately for the patient in this case, the variant of uncertain significance had been reclassified to benign. But these are patients who we may see early in life and who will be followed throughout their entire life. And our knowledge is going to continue to develop as they continue to live their lives and try to avoid any medical issues. And so being vigilant about keeping up with this data and being aware of advances in the field is essential. Just to come back to sort of simple clinical guidelines, our 2022 guidelines of aortic disease recommend genetic testing in those patients with any features of a inherited aortopathy, such as Marfan syndrome, Louis-Dietz, or vascular Ehlers-Danlos. Those with thoracic aortic disease under the age of 60. And importantly, those with a family history of thoracic aortic disease or intracranial or peripheral aneurysm, even in the absence of a clearly identified syndromic condition. And this is a growing population and speaks to the importance of still acquiring a good family history and recording it in the chart. Because there are patients, and we've had patients who have inherited aortopathies that are yet to be described or discovered. Additionally, those patients with what is thought to be sporadic disease, imaging can be, who have aneurysms in at-risk family members can also be considered for genetic testing. These are the patients we want to consider testing. Which genes should we test for? That's based off of factors related to the evidence we have around the genes. This figure is from a somewhat dated now 2018 paper, but showing all of the sort of genes associated with arterial aneurysms that are described in their varying levels of evidence. The patient sitting in front of us, including whether that patient is adult or pediatric, the lab capability and cost. Our current UW aortopathy panel includes 28 genes. It's updated. There's a constant review of literature for new information, but just due to the logistics of actually updating the laboratory test, it's updated about every 2 years. It is used for adult and pediatric populations at Seattle Children's too. So there are some mutations on here that fall into the lower evidence categories, but maybe more prominent in pediatric populations. And our lab capability is currently still based on targeted capture probes, but may expand to exome sequencing in the future, which would greatly improve the ability to add on other testing for other variants. Common questions that may come up when considering referring a patient for genetic testing: when to refer. The old adage of if you don't know what you're going to do with the test, don't order the test still applies. So any discomfort in ordering or interpreting genetic testing is a totally reasonable reason to refer to our genetics colleagues. Genetic counseling and cascade testing can also be a really helpful resource. This involves reaching out to other family members, potentially accessing their medical information and navigating ethical and legal issues. And the genetics clinic is very well set up to assist with that. Follow-up in genetics clinic, these are typically one-time consultations for diagnosis and post-test counseling, but they are certainly available to follow up for patients as needed. And then the question often arises of when should I retest my patient in whom I suspect an inherited aortopathy but does not have an identified pathogenic variant. And this can be considered about every 2 to 5 years, sort of based off those cycles of both discovery and update of our lab testing. So we come to sort of integration of these pieces. We take a good family history to understand our patient's risk. Where appropriate, we pursue genetic testing to further characterize that. When uncertainty exists, we follow our patients over time. We can do serial imaging and consider what the progression of their disease is. And then we consider special circumstances in their life, such as pregnancy, that may alter their risk and guide their management. And then from this, we can provide our patients with a plan, a way to get them safely through the events of their life and through any condition they may have, avoiding the complication of dissection or death. So in the last about 10 minutes that we have here, I want to just summarize some of the pertinent elements of individual surveillance and management of thoracic aortic disease. This is sort of focused on a review of elements of the 2022 guidelines, which, though they've been out for a while, we are still pulling them up and reading them through regularly in the aortopathy clinic because there's quite a bit of granularity and complexity. And so we'll try to summarize some of that here. Medical management among patients with thoracic aortic disease is still undergirded by maintaining optimal cardiovascular health. Hypertension is the greatest sort of non-inherited risk factor for thoracic aortic disease, and so should be diligently monitored and treated. Among patients with identified inherited aortopathies, there are guideline-recommended medical therapies, including beta blockade and or angiotensin receptor blockers in Marfan's and Loeys-Dietz. And then in inherited aortopathies, beta blockers are recommended, but only by expert opinion. And then the avoidance of potentially harmful medications, such as fluoroquinolones, or activities such as high-intensity exercise that may increase the risk of dissection, although more routine exercise is still encouraged to maintain cardiovascular health. Imaging intervals among patients can vary. Oftentimes, one of the questions is how often should I be echoing or imaging this patient? This slide, kindly provided by Dr. Otto, who gave a related talk to us as fellows a couple weeks ago and made some very helpful summarizing figures that I wanted to share with the audience more broadly here. In Marfan syndrome, these patients require echo imaging as well as cross-sectional imaging of the entire aorta, and then can be monitored annually. If they do undergo surgery, then and demonstrate stability over time, their monitoring can spread out a bit. In Loeys-Dietz, it should be noted that in addition to imaging of the entire aorta, these patients require imaging of their intracranial vessels due to the risk of intracranial aneurysm. In patients with Turner syndrome, because of the use of the aortic size index to assess dilation, we incorporate that into monitoring, and then whether or not they're at risk based off of the ASI, their monitoring is either annually or can be spread out considerably. And in those with bicuspid aortic valve disease, cross-sectional imaging is only required if you can't see the ascending aorta well on echo, and first-degree relatives should be screened, particularly in those in the case of a proband with a dilated aorta. When we get into the areas of surgical indications for thoracic aortic disease, it becomes much more granular, and this is reflective of trying to basically reconcile our older risk predictor of aortic diameter with some of our newer knowledge about the individualized nature of these patients. And this is where I would just emphasize too that in cases such as Loeys-Dietz or familial thoracic aortic disease, it really is important to interpret that genetic testing and note which mutation the patient or which variant the patient may have, because it actually can impact the recommendation for consideration of aortic replacement, aortic surgery. I'll also note that separate recommendations are provided in the guideline for pregnancy, essentially just brings down the threshold for each condition, but should be kept in mind for female patients. And then in some conditions, such as vascular Ehlers-Danlos, these patients, unfortunately, are still so prone to dissection at normal diameters that we don't yet have effective risk predictors to be able to treat them and prevent these events. You saw the different risk predictors on that slide. The guidelines are challenging as well in that risk factors vary across conditions. And so anytime there is a family history of dissection, or if you're seeing rapid growth and monitoring over time, these are high-risk conditions that will move a patient towards more aggressive management, towards surgery. Aortic phenotype can be important and is considered in Marfan syndrome in the case of a diffusely dilated aorta, and in bicuspid aortopathy or sporadic thoracic aortic disease in the case of a root phenotype shown there with a prominently dilated aorta at the level of the sinuses. Extra aortic features in some of the syndromic conditions are thought to be associated with increased risk, as is coarctation in the case of bicuspid aortopathy, sporadic aortopathy and Turner syndrome, or bicuspid valves for Turner syndrome patients. Another slide to share from Dr. Otto. So this was, I showed you the table that sort of starts with the diagnosis and then interprets it for the patient. But oftentimes we're seeing people, and the first piece of data we have in clinic is what their aortic diameter is. And then we're trying to work forward from that to decide what we ought to do about it. And so the same data presented in a different form. Patients with an aortic diameter over 5.5 centimeters, familiar to all of us, has not changed significantly in bicuspid aortic valves and sporadic aneurysm. That's an indication for surgical replacement. A diameter greater than 5 centimeters in the case of Marfan syndrome or bicuspid aortic valve pre-pregnancy is still a class 1 recommendation with 2A and 2B recommendations listed as below. For patients with an aortic diameter greater than or equal to 4.5 centimeters, those with certain variants in Loeys-Dietz syndrome or Marfan syndrome patients, or non-syndromic heritable thoracic aortic disease patients that are contemplating pregnancy, have a class 1 indication for replacement, and 2A and 2B indications listed below. And then in patients, the most aggressive sort of recommendations, no class 1 recommendations at the level of 4 centimeter diameter aorta, but in those patients with TGFB2 mutation and high risk features can be considered for aortic surgery. And then some of the syndromic categories with high risk features or pre-pregnancy can be considered as well. And lastly, Turner syndrome, based off the aortic size index greater than 2.5 centimeters per meter squared, class 1 indication in the pre-pregnancy situation, and then with high-risk features or just with aortic dilation alone. Just to put this all together in sort of a concluding case for us, I want to share the case of a 33-year-old male. This was a gentleman who had a history of a type A aortic dissection, already notably at a very young age 27, underwent emergent repair. He was referred for genetic testing at that time. He was lost to follow-up in clinic, but did have a repeat CT under some circumstance in 2018, which had stable appearance of a surgical repair, and then represented to our vascular surgery clinic in 2022 to reestablish care. He lived a pretty normal life, worked in construction. He had noted that he had thin skin on his legs and frequent tears, so he wore heavy pants and gloves at work. He had been partially motivated to re-engage with care because of his family history, which had just evolved with the birth of his son, who had been born with club feet and was diagnosed with a bicuspid aortic valve. His other first-degree relatives, parents, siblings, had no known disease, but his maternal grandmother had an aortic aneurysm. And so he was sent for a repeat CT scan to evaluate, and had the astonishing finding of a severely dilated aortic arch up to a diameter of 7 centimeters beyond the distal edge of his prior repair. He was referred urgently, emergently for surgery and underwent a successful zone 2 arch replacement with a frozen elephant trunk and a left CS transposition. He unfortunately, he then subsequently underwent TEVAR extension 5 months later, but unfortunately had continued degeneration of his aorta and ultimately underwent an open thoracoabdominal aneurysm repair 9 months later, fortunately successfully, but a very high-risk intervention. And in part high risk because during this period, his genetic testing had been sent and had resulted actually with pathogenic variants in COL3A, which you'll remember was involved in the collagen organization within the extracellular matrix, as well as the SMAD3 gene involved in the TGF-beta pathway, giving him a dual diagnosis of vascular Ehlers-Danlos syndrome as well as Loeys-Dietz. The first case that we know of in the literature of this. So a very complex patient, very technically difficult surgically and high risk with also implications for his family. And this just gives me a brief opportunity to touch on our multidisciplinary thoracic aortic program. This was partly the topic of Dr. Zettervall's grand rounds back in December, but this brings together our cardiac and vascular surgery, cardiology and vascular genetics teams to take care of these very complex patients and ultimately their families. And this is what these patients often require because of the need for lifelong monitoring, genetic counseling, and the certain need ultimately for technically challenging surgical intervention. And this is borne out in the data that these patients with multidisciplinary thoracic aortic programs do better in their outcomes. So as institutions reach about the 40 cases annually mark, we see that the actual mortality from surgical outcomes is less than the predicted risk. And certainly in the case of these complex patients, this aggregation of resources is really best for patient care. So just to conclude with kind of summarizing statements, individualized care for the patient with thoracic aortic disease stems from accurate diagnosis of etiology, which portends prognosis and guides clinical management. Assessment of risk factors via family history, comorbidities, and special circumstances such as pregnancy. Prevention of comorbid and contributory cardiovascular disease through optimal medical management. Timely surveillance and referral for surgical management when indicated. And I think personally, something that's been impressed upon me in my years in the aortopathy clinic with Dr. Otto is the importance of patient education. We talk to all of our patients about the signs and symptoms of aortic dissection, what it's important to do, how to take care of themselves and others. And you know, ultimately, these patients become responsible for their own health and for sort of encouraging family members to be tested where needed. And so I've been impressed to see that we've had patients even who have suffered aortic dissection, but were able to get timely care and survive their episode because they understood their disease process. I'd like to thank Dr. Otto and Dr. Buber for their help, and Dr. Hisama from the genetics department for their help in developing this talk, Dr. Ulrike Schwarze and Dr. Peter Byers for helping educate me a little bit about some of the ins and outs of our genetic testing program, and the entire UW MTAP program that takes care of these patients and that I've been privileged to work with during my time as a fellow. So thank you all very much. That leaves a few minutes for questions.
Outstanding talk, Lee. Thank you very much. And thank you for explaining to me what I've been doing in the clinic for the past 5 years. Any questions from the audience? So.
Thank you, Lee, for the great talk. That was amazing, man. So you mentioned that the proportion of thoracic aortopathies from inherited forms are increasing. I just wanted to know, what are some reasons that you think that may be? Is it because we're ordering more genetic testing as the cost is coming down, or retreating traditional risk factors more efficiently?
That's a great question. That's a great question, Shannon. So thank you. I think that, you know, the prevalence of genetic testing and honestly clinician awareness of sort of noting these histories, particularly for the non-syndromic inherited aortopathies, is helping increase the sort of rate of diagnosis. And I will say there's some interesting studies that I did in my reading, even of studies that have looked at patients presumed to have sporadic thoracic aortic disease, and who were subsequently underwent exome sequencing to kind of look for other variants that may predispose to speak to actually inherited forms of disease. And I think that new variants are continuing to be identified, and some of that we may see that some portion of the sporadic disease population is reclassified into the inherited aortopathies. Thank you. Yeah, for me. Just have the one microphone. Things like it.
Great talk, Lee. I was surprised to see that having a particular gene it makes a difference in clinical care. Is that based on data? Because the amount of patients is very small. I mean, it's not. I don't know much about this area. It's great to see. I'm just curious. What is that based on?
That's a great question. In the 2022 guidelines, most of those tables that encompass the sort of individual genes and the variation management, the level of evidence is not high. I didn't personally, I wasn't able to sort of dig into those studies and see exactly, what their design was and sort of what the degree of evidence was. But, most of these are still at a sort of pretty low level, and in the vascular Ehlers-Danlos population, we're not even able to gather enough data to make any preliminary recommendations. So it's an excellent point, and one that I should have looked into. Yes, Dr. O'Brien.
Thanks, Lee. That was great talk. I really appreciated it. I guess my question revolves around this gulf between genotype and phenotype, right? Because particularly the issue of VUS, which is also especially a problem in members of diverse population groups. So is there a way to refine imaging to beyond just using a ruler and pi r squared to identify the tissue-based risk? I struck, for example, by the histologic finding that intimal thickness was less. Could you use something like OCT or IVUS, understanding those are invasive, but could you use those to refine risk in people who may have for example, a VUS, but determine their risk?
Yeah, thank you. It's an excellent question. It's certainly one that occurred to me in preparing this talk as I kind of learned more about what we could look for as predictive testing to kind of better risk stratify patients. I did not come across any studies looking at imaging techniques, for example, that might characterize the health of the aortic wall like you're describing. And nor did I come across anything that would be like a serologic marker of that. I don't know that evidence doesn't exist, but in the research that I was able to do, I didn't uncover anybody that had looked at that. Yeah, if you would.
It's a very important topic, and I think that two things that we're looking at, trying to look at more in imaging studies, is number one, what Lee mentioned about the aortic heights, and when we try to add into the equation, and it actually is I think in the guidelines, when we have the ratio between the aortic height and the diameter of the aorta or the area of the aorta. And that goes into the guidelines as a two-way indication to further risk stratify patients with quote unquote normal aortic diameters. That's number one. And number two, what we're other centers trying to do in 4D MRI imaging is try to measure the compliance of the aorta. And so when we try to measure the compliance of the aorta through the cardiac cycle, that gives you a pretty good idea of how stiff it is.
Yes, there is. So first of all, I just want to say for the cardiologists that please don't overinterpret VUSs, because we in genetics know that 80 to 90% of them will turn out to be, when we have more data, reclassified as likely benign. Okay, so the problem is, of course, we don't know exactly which 10 or 20% are going to be upgraded to likely pathogenic, right? So what you're suggesting is a really good approach, is more detailed phenotyping. On the genetic side, we actually do have some tools. They're not perfect, but for example, we can do family segregation studies and see how the variant tracks in the family. And if there are 2 affected or 3 affected family members, which again takes enrolling the family and doing more phenotyping of them, we can see whether it segregates with the phenotype, and then that helps to reclassify it. In addition, there are newer approaches such as MAVES, multiplex assays of variant effect, which some people in cardiology are working with also, which are basically like high throughput ways of assaying thousands of variants of uncertain significance. So essentially you can create every potential VUS in a gene, express it in a system, and then based on function, you can get additional information. In the genetics field, we're working on how much weight to put on these in vitro assays of function and how well do they predict clinical outcomes. But that's a really active, exciting area of research. But this is a huge problem for clinicians and for patients, is VUSs. But again, please don't overinterpret them. The default is we say most of them will turn out to be normal. So don't treat them, don't test family members for them unless genetics tells you to.
So Dr. Otto wants to go online, and so we'll try to hear her.
Yeah, can you hear me?
We can.
Good. So that was a fantastic talk. I mean, that really was a great overview. And I think it just illustrates, the kind of complexity, but we're just kind of like at the cusp of being able to understand these conditions. And I think, the discussion here, has highlighted the 2 aspects. One is the genetics and one is the imaging. And what we're trying to do is we're trying to identify which patients are at risk of dissection or other adverse outcomes and should be followed closely and have intervention, versus who is really have a benign condition and is not going to need that degree of follow-up. And I think our tools are very crude right now. So the genetics is improving. And as Fuki emphasized, I mean, we definitely rely on medical genetics, both at our weekly conference and by sending patients to medical genetics to try to interpret. And we would really like to have better genotype phenotype correlation. So we could say, with this genotype, we need to follow you very closely. With this one, you don't need follow-up or a different schedule. Versus the imaging, right now we're so focused on anatomy and the looking at compliance and tissue characteristics, something, one of our fellows tried to do years ago in the bicuspid valve population. We so far don't have a good way to identify anatomically who's at risk. And I think we're just in the early days. We really want to know, is the tissue at risk of dissection, and basing it just on diameters, or now we're adding length and areas and ratios and other things, I think is a very early stage. So I think it's an exciting space, and we're going to see a lot of advances over the next decade or 2 in terms of managing these patients and making a more precise diagnosis.
One question that we have online from Rashid is, what is the risk of over testing or over sending genetic testing?
It's a good question. I think, that one of the values of being in aortopathy clinic and seeing these patients, as Rashid is as well, is that, we realize that we do have some time to follow patients. And I think there's been a number of occasions where we send testing and that testing may come back with uncertain results. And those patients are reviewed at MTAP conference and discussed, and the patient's informed, but it doesn't necessarily drive harms of testing in terms of, committing us to do something that could present risk to the patient. And so, I think when the indications are there to genetically test and detect something that may be useful to guiding the patient's management, and just to acknowledge that it may present us with some uncertainty, and have some sense in our mind of what we'll do in that case, how we'll counsel the patient, how we'll discuss with colleagues, and realize that sometimes the best course of action for the patient is just to follow them and continue to be their doctor, and keep the conversation going as new information becomes available.
Lee, thank you again for a wonderful talk. It's been amazing. And thank you for joining us today.